This is, of course, the masterclass for February 2025, and we have the fabulous Vikki Columbus with us here today. She is also in the circle, and she knows lots and lots of things medical, and isn't tied to like one kind of medication or one kind of thought or another. So a good unbiased source for finding out things that we need to know as life goes on and bodies change. And the subject today is human hormone replacement therapy, different than human replacement therapy, but not always. So with that, Vikki, I'm going to turn this over to you.
Okay, awesome. Thank you, Linda, so much. I am going to try and share so that you don't see my notes.
We see your slide. It looks
Yay!
perfect.
This is the biggest accomplishment. Isn't that crazy? Like, this is what I'm most proud of, actually successfully sharing my slides. Okay, before we get started, I need to say the following out loud for liability purposes, which is that this class is for general informational purposes, does not constitute the practice of pharmacy, medicine, nursing, or professional health services, including the giving of medical advice. There is no healthcare professional-patient relationship formed, and the use of this information is acted upon at the user's own risk. The content that I'm about to share is not intended to be a substitute for individual professional medical advice, and class participants should not disregard or delay in obtaining medical advice for any medical condition, and they should seek the assistance of their own healthcare professionals for such conditions. Okay. Got that out of the way, as per our legal counsel. So the first thing I want to talk about is the definition of menopause. There is a tremendous amount of confusion about what exactly menopause is. So I've got some options here. So the first, is it the period of time when we experience symptoms like hot flashes, night sweats, and brain fog, and rage, Kimball? Is it our last period? Is it when we stop ovulating? Or is it all of the above? Who thinks it's A? Anybody? Show of hands? No? Who thinks it's B? Nobody thinks it's B? I can't see everybody, so let me know if people are. How about when we stop ovulating? Does anyone think that's what it is? It is not all of the above. It's
Dang it.
actually, I know, it's actually B, our last period. And interestingly, the way you diagnose menopause is retrospective. So you have to wait a year from, or 12 months following your last period, not having one. And at that point, you can officially say, I've been through menopause. At that point, you are postmenopausal. And I'll go through a timeline that shows kind of the different stages of fertility throughout a woman's lifetime. So obviously it's natural, it's inevitable. On average, it happens around age 50 in African American women, 51 in white Caucasians, and 52 in Asian Americans. It can happen at, any age in and around there, but anything before age 40 is considered premature, and obviously medical help should be sought at that point. So here's the timeline. So this is kind of the official way that menopause is staged, or reproductive staging, they call it. So if you look at that green through line in the middle, that has nothing to do with years or age. That's just the stage. So your stage could be 0, -4, +1. And you can see starting on the left is early reproductive life. So that's kind of when, you know, you go through puberty, start getting your periods. They can be irregular for some time. And then during peak, you know, you have regular cycles, your hormones are you know, kind of consistent at that time. So they're different acronyms in here. So FSH, AMH, and inhibin B are all hormones that can be used to assess a woman's ovarian reserve. So that's how many eggs you have in your ovaries. So people who are having fertility issues will go in and see a specialist, and they check out your ovarian reserve. So what we're talking about today is kind of, you know, starting in the middle over to the right hand side. So menopausal transition starts before that FMP, which is the final menstrual period, which we just discussed is the definition of menopause. But perimenopause is kind of the big fuzzy cloud that people don't know a lot about, when you can start getting a lot of these symptoms, right? So, you know, very intermittent periods, or, you know, big changes in the volume of your period, or even some of the menopause symptoms can start showing up during perimenopause. So the hot flashes, the night sweats, the irritability, the brain fog that can trickle in. This says 1 to 3 years before menopause, but in, you know, anecdotally, I've heard of people basically their entire 40s are kind of affected by this, depending on obviously their other health factors. So then we get into, you know, the right side of that FMP, and that, like I said, is called postmenopause. And that's when you get the hot flashes, the night sweats, the brain fog most commonly. And then later, later menopause, you know, 5, 10 years and on, is when the symptoms are more urogenital, meaning to do, you know, with vaginal atrophy. So the thickness of the vaginal walls really, you know, can shrink, and also with urinary urgency or incontinence. So those are all symptoms that can be um, helped with hormone replacement therapy. So here is what happens in our bodies to these hormones over time. So estrogen, you can see, kind of goes a little wonky. That's, you know, just the monthly fluctuations of the estrogen. Progesterone is more steady over time and declines more gradually. And testosterone is a very, very gradual decrease over time. Now, men have these hormones too, even the estrogen. In fact, estrogen is in men and women the primary hormone needed for bone density, like building bone. And so, you know, our hormones kind of drop off like a cliff, or they get the nice gradual, easy ride down. But they're important for them too. So, you can kind of see before the final period, there's a lot of erratic activity with estrogen levels, and progesterone and testosterone are a much more gradual decline. Now, before I get into the next slide, and I would really appreciate a show of hands. You can use the little emoji or just raise your hand, but how many people here are under the impression that estrogen causes breast cancer? If you use or take estrogen, it increases your risk of breast cancer. Is anyone under that impression? No?
So my experience, or what I've been told over the years, is the old replacement estrogen replacement therapy.
Mm-hmm.
Those fake hormones are what were causing cancer and uplift, and it matched along with the pill, the side of, the percentages of the pill. The newer ones, the bioidenticals, supposedly got rid of that. That's what I've heard.
Good. You have good healthcare providers. So there is, and I'm talking to a group of, obviously very highly educated women. So I'm sure your experience is a little bit different than a lot of the general population, but that perception is still incredibly prevalent that estrogen causes breast cancer. And so for decades, women were absolutely terrified of estrogen. It's specifically, postmenopausal. For some reason, the logic didn't apply to birth control, like you just mentioned, Michelle. But so that is something that, we're trying to overcome. And so the more we talk about this, I think that the better off we'll all be. So the history of HRT and that perception about estrogen and hormone replacement causing cancer came from a giant study called the Women's Health Initiative. And this was out in the 1990s, early 2000s. And Michelle, you hit the nail on the head. That study, and it was massive. I mean, like tens of thousands of women, but they did use synthetic estrogen and progesterone, specifically Premarin, which I'm sure everybody's heard of by now, comes from pregnant mare's urine, and medroxyprogesterone acetate. So the results of that study, in fact, they ended the study early because of preliminary data showing that women had an increased breast cancer risk, as well as coronary heart disease, stroke, and total mortality. So the one thing you did say that I want to address, Michelle, is that the reason that the breast cancer was brought up is because they were synthetic. That is partially true, but it is mostly because of a couple other factors, which I'll go over in a minute. But there's a big push now in the medical field, especially there, there's a group of physicians that are in their 50s or women, and they call themselves the menopause. And they've kind of banded together. I know, isn't that great? They've banded together, and it's their mission to make sure women know that these are safe and they're effective, and that the studies were flawed. They were absolutely awful. So this last quote here is from a doctor who I subscribed. He's got a subscription for healthcare professionals, and he's absolutely brilliant. He is a scientist and an economist and a physician, and he broke this down in such great detail. But it is his position that this is the most botched study in medical history, and that there are a couple of generations of women that were robbed of appropriate health because of how terribly executed and interpreted this was. So the messaging in the early 2000s, estrogen increases breast cancer risk and risk of thrombotic events like blood clots. Now, last year, they re-reviewed that very same study, came to some different conclusions, but what this menopause and some of these other, kind of leading practitioners are now saying is that there is no clinically significant difference in breast cancer risk with estrogen or progesterone, even like Michelle said, not even with the synthetic forms that were used in the study. Now, nobody uses those anymore. You shouldn't be taking them. I'm not suggesting that. just what the data said. The only thing that is still valid is that the oral estradiol can slightly increase the risk of blood clots, but nobody really takes estradiol by mouth. It's typically topical, and there is no elevated risk with that. So this study was flawed for many reasons. One of them is the synthetic forms that were used instead of the bioidenticals. There were a lot of women that had had hysterectomies in the study, which isn't necessarily bad. It just confounds the outcomes and the conclusions. Many of the women were already very unhealthy. They had a lot of other medical conditions. And the most important thing is that most of the women in the study had already been in menopause or postmenopause for a decade. A lot of these women were in their 60s, 70s, etc. And so they'd already gone through a lot of the symptoms that we were looking to help. And so it was really just horribly designed. And then this is my favorite part, because this is what we do here at SGRX. So for those of you that don't know, my company is a pharmacy benefit management organization. So when new drugs come out on the market, we've got a committee called the Pharmacy and Therapeutics Committee, and it's physicians and pharmacists and nurses, and we all get together once a quarter. We go through the drug studies and evaluate them using pharmacoeconomics, which is kind of a little taste of what we've got here on the screen. So absolute risk reduction and relative risk reduction, these are measures that are very commonly manipulated by manufacturers when they want to get their drug to market and it has kind of lackluster evidence. So for those of you that are, kind of mathematically inclined, absolute risk reduction is exactly what it says. So in this example, 2% versus 3% risk of an event, the absolute risk reduction would be 1%. Relative risk reduction does not take into account the denominator. It just compares the two numbers. So in this case, it would be a 50% increase risk, even though we're talking about a very slight. This could be in 5 people, in which case it'd be a big deal. Or it could be in 10,000 people, in which case it's not a big deal. And this is exactly what happened in this study. They looked at relative risk instead of absolute risk. So here's a chart of the outcomes. So there were 4 groups in this study. There were 2 placebo-controlled groups, and then the 2 study groups were Premarin without the progesterone for the women who had had a hysterectomy, and then both together. And the breast cancer incidence, the difference in the Premarin only cohort was 1 case fewer than the placebo group. In the combination therapy group, it was 1 case more than placebo. So the absolute risk difference was 0.1%, but the relative risk was 25%. And that's what everyone latched onto and spread like wildfire. And that's why we're all terrified for decades of estrogen. So, what if you are a woman with risk for breast cancer? I know personally, I'm very blessed to say I am not. But if I was, I think I'd still be a little apprehensive because, they're estrogen sensitive types of breast cancer and tumors. So this is, something that's also been investigated, and there is no clear correlation between the proliferation of breast cancer cells or tumors and estrogen. That isn't to say that it is positive or negative, it's just unclear. So what we do know is that estrogen shouldn't be given to women, obviously, that already have breast cancer. And most often, women that develop breast cancer have low estrogen. These are just facts. There's no clear yes or no answer. The only thing that I would say is everybody, breast cancer risk or not, should discuss in great detail with their healthcare provider whether or not these agents are appropriate. So, what happens because of the decline of these hormones over time? So, the things that we feel because of low estrogen, progesterone, and testosterone, vasomotor symptoms are obviously the most well-known: hot flashes and night sweats. Skin dryness and laxity, that is estrogen mediated as well. Reduced sexual desire can be testosterone related. Vaginal atrophy, we talked about that earlier. That's kind of a later stage issue. Urinary urgency, reduced vaginal lubrication, brain fog and memory disruption. And, oh, here you go. I didn't put rage, but irritability and depression, close. But I feel you on the rage. Absolutely. Now, this last slide is what I kind of like to think of as we're here for a good time, and the next slide is we're here for a long time. So these are the conditions that, lead to reduction in mortality and morbidity that are also hormone mediated. So bone density is the most common. Now, this one is incredibly important as we age. The probability of someone falling during their lifetime, once you're 65, is 25%. You have a 1 in 4 chance of falling, and 10 to 15% of falls can be fatal. Now, even more for women, because we're smaller, we have, on average, we have less muscle mass, and we're less active. Our bones are also weaker. So I think I talked already about the fact that estrogen is what stimulates our bones to grow. So when you do, I'm sure everyone's heard, that you should do weight-bearing exercise to help with your bone strength. So that puts pressure and gravity on your bones, and that's what stimulates them to grow. And estrogen is the hormone that mediates that process. Yeah, it declines very, very rapidly in women, not so much for men. So the next is type 2 diabetes. So both estrogen and progesterone play a role in insulin sensitivity. So for those that might not know, that just means how sensitive your cells are to insulin, which helps with the uptake of glucose. And so once you become less insulin sensitive, the glucose is not used by your cells and then kind of shuttled to your liver for storage. And that's where the weight gain comes from. It's turned into glycogen in your muscles, in your liver, and fat, and around the waist area. So estrogen is protective also against Alzheimer's disease. Yeah, I know. So this is something that I learned in the last couple of years, just as I've kind of been slogging through this whole journey myself personally, that we have a lot of estrogen receptors in our brain, and actually, estrogen is very anti-inflammatory in your brain, and it protects the degeneration of neurons up there. And so, hence the, the Alzheimer's disease benefit. And then also, same thing is true with cardiovascular disease. So the one thing I do want to say, though, is with the cardiovascular disease, it's protective against future decline and outcomes, but it won't reverse existing ones. So the best time to actually initiate hormone replacement therapy to reap all of the benefits that I have talked about is actually during perimenopause. So a lot of people don't realize that. There are some of these expert physicians that think every woman should get baseline hormone testing when they're in peak fertility, like 20s and 30s, just so that because my levels and Linda, your levels could be different, but we could be functioning optimally for our own bodies. So the levels that they have as standards are very average, right? So the earlier you can get them tested, the better. And then the earlier you can start with the hormone replacement, once once you're symptomatic. Obviously, you don't want to just start using these for no reason, is really the best to preserve. It really helps preserve, health in all of these different areas. Now, I can share these after, and I'm not going to go through all of them, but there are, many different kinds of hormone replacement products. This is a chart of the estrogen products, and just like Michelle mentioned, the products now are what's called bioidentical. So basically, that just means they mimic what your body produces naturally. The synthetic products, the non-bioidenticals, are modified a little bit, and they're done that way on purpose, primarily originally, for oral contraception, because they wanted to increase the binding capacity, because obviously, it needs to be, 99% effective to prevent pregnancy. So now the newer products are kind of, they mimic really what goes on in your own body. And so the safety profile is much better. Now, it used to be, before there were so many FDA approved bioidenticals, it used to be that you could only get those from a compounding pharmacy. And a lot of times you'd have to go see a naturopath, or I think somebody on here said they saw a homeopath. But now, mainstream allopathic physicians, if they are, well educated and up to date on the topic, are able to prescribe these versus the compounded ones. The other benefit is that these are FDA approved, and so that means the manufacturer has to comply with good manufacturing standards, and so the consistency from batch to batch and lot to lot is much better. That's not to say, I'm not trying to say the compounded one should be avoided. Like anything, if you have a great compounder, I'm sure their product can be terrific. The other benefit, though, to the FDA approved products is that probably going to be covered by your insurance, where the compounds typically are not. So you can see there are multiple options now. Oral transdermal just means through the skin. So that's your creams, your gels, your patches, and then the vaginal products, anything you insert or apply topically, vaginally. Same thing goes with progesterone. So progesterone, the reason it's given along with estrogen is because if you give estrogen by itself and you still have an intact uterus, if you haven't had a hysterectomy or an ablation, there's a little bit of dispute as to whether or not progesterone can cause this, but estrogen will make the lining of your uterus grow, and if that goes kind of unchecked, it can lead to uterine cancer or uterine thickening. And so you give progesterone to kind of modulate that. That's why they're given together. And a lot of the symptoms that we talked about are actually progesterone mediated too, like the irritability, the depression, some of the kind of more cosmetic. I don't want to say it. So progesterone makes your hair thick. And it makes you feel good, puts you in a good mood. It's the one that is responsible for PMS. So the only thing I will say about progesterone too is, it's a balancing act with that one. Like you have to walk a fine line, because if you have too little or too much, you can be irritable. So it's really important to have a good relationship with your provider so that you can have good communication back and forth about your dosage and getting it titrated properly. What else do we have? Oh, these are the combination products. So both estrogen and progesterone, just kind of for convenience sake. So what about testosterone, the third hormone that I have mentioned? So this one can help with libido, muscle mass, and energy level. Believe it or not, testosterone is the most abundant hormone in women. The reason that it kind of doesn't seem that way is that our body binds it up. So there's not as much of it floating free in our bloodstream. So there is another product called DHEA that is a precursor of testosterone. You can actually buy that over the counter. The problem with that is we as women are very sensitive to the effects of testosterone, so you can very, very easily overdo it, and then the side effects are not pleasant. And at this point, only about 10% of women really need testosterone supplementation along with the estrogen and progesterone. It's also available in the same kind of delivery mechanisms as the other two. Like I said, the side effects are not fun: acne, hair loss, voice changes, hair growth in places where you really don't want it. So again, it all comes down to having a good relationship with your prescriber. Talked about that already. So other pharmacologic treatments for vasomotor symptoms. So again, that vasomotor symptoms are the night sweats and the hot flashes. So antidepressants and gabapentin have been used, and there's no exact known reason why they work, except we talked about a little while ago that you have a lot of estrogen receptors in your brain, and that's where these drugs work, right? So we found out during COVID that long COVID really responds well to the SSRIs. And it's because you have sigma receptors in your brain, and these really can help with those. The only one that is kind of an outlier is paroxetine, which the brand name used to be Paxil. Anybody who's taking tamoxifen should not take that one. Another drug, gabapentin, that was an anti-seizure medication, is also effective in reducing vasomotor symptoms, but has a lot more side effects than the antidepressants. Now, this is my personal opinion, not literature. It's not part of any guidelines. When I think about health, I think I don't have an SSRI deficiency at this point in my life. I have an estrogen and progesterone deficiency relative to my younger self, right? So for me, these are kind of for people who, have a very complicated history with the breast cancer risk and the, other concerns, then absolutely. But I think, men have had access to testosterone forever, so I think it's time that we really look at the underlying cause of a lot of these issues. So, just kind of some miscellaneous things that I wanted to bring up. Um, the transdermal estrogen is safer than oral. I think I mentioned that, relative to blood clots, stroke, etc. And that's because it doesn't go through something called first pass metabolism. When you swallow a pill, a tablet, a syrup, anything like that, it goes through your GI tract, and then it's filtered by your liver. And that's where a lot of the problems with estrogen were found. And so transdermal through the skin, creams, gels, vaginal, etc., bypasses your liver altogether. So if you have a family history of any of these medical issues, this is the way to go. Now, there is an issue with the tests for hormones. And unless you have a very astute practitioner, you're going to get unreliable tests and test results. A lot of them use enzyme-based tests, which are highly inaccurate. So you want to ask for something called LCMS test. The bioidentical compounded products, they do saliva tests instead. But again, I think you most often have to pay for those. I don't know too many places that cover them. The last thing I want to talk about is that there is an absence of data relative to how long to use hormone replacement therapy. Again, it's between you and your healthcare practitioner. It used to be, 10 years. It used to be, don't use it if you're over, 70. But that's not true anymore. There's no data to support any of those claims. And I feel like, we're kind of at the beginning of a new era now where this is all going to be much clearer, studied better. Before the WHI, the only studies done on estrogen were in men. It's absolutely insane. So, in general, drug studies have been done on men. And so we're seeing more and more research in the appropriate cohorts. Now, there's something else that kind of confounds all of this that could be playing into not only the symptoms, but the risks. And this other thing has been linked to a 30 to 50% increased risk in breast cancer. There have been many case-controlled and cohort studies that consistently observe this increase, which this is from Google, by the way. I just pulled this off Google because I wanted to see what the prevailing messaging is. Because if you Google estrogen, you still get breast cancer risk and use with caution. But this says it's a modest increase. Now, this thing that I'm talking about also is a huge cause of sleep disturbance in peri and postmenopausal women. And once we are postmenopausal and we don't have all of the estrogen floating around in our brains, anti-inflammatory, protecting those neurons, This kills them. This is toxic and kills the neurons in your brain. Does anybody know what this is that I'm talking about? No? It's alcohol. Now, I am not, pushing sobriety. I'm not advocating that everybody needs to quit drinking. Really, what I find fascinating is the messaging, right? So we talked about absolute versus relative risk, and they looked at that manipulated relative risk number, which was 25%. So even if that was true, alcohol has a much higher risk of causing breast cancer. So it's just fascinating to me. And when I look at it, it's like everything's a choice in life, right? You want to have a couple drinks, go for it. I'm not trying to discourage or encourage any kind of behavior. I just think it's we all need to be educated with the actual facts. Okay, so some takeaways and expert resources. It's okay to ask for a second opinion. If your family doctor, your PCP, isn't well educated on this topic, go somewhere else. Find a clinic. There are menopause clinics. You can go online. One of my favorites is Kelly Casperson. She has a podcast called You're Not Broken. There's the International Menopause Society, which I pulled some of this information from. And then there's a group called Menopause Experts, and they have a portal where you can go and plug in your zip code and find physicians in your area that are versed in menopause treatment. And this last one is a plug for my business. So this is one of the things we do, right? So pharmacy benefit management, primarily, we process claims, we set up networks, we help people with their drug coverage, their formulary, their benefits. But we have a group of people that do medication therapy management. And so groups enroll with us and we look through their data and see, okay, you have a lot of people with diabetes or a lot of people with asthma or, a lot of folks with COPD. And so we've got nurses and pharmacists and pharm techs that kind of case manage them individually. So that's why I'm talking about this today and kind of why I'm not because of my business. I mean, because this is part of my business. That's sort of interesting. So that's that for today. Does anybody have any questions?
So many.
Oh dear. I cannot guarantee that I have answers. First of all, I need to another caveat, which is, I'm one of the owners of the company, and I cannot tell you how difficult it was for me to put these slides together because I've got, staff that does all of this now. They do all of the clinical deep dives, the presentations. And another thing that happens around menopause is exacerbation of ADHD. So I had no idea I had ADHD until I hit menopause. And it is almost impossible for me to sit still. It was torture putting these slides together. All that to say, I might not know the answers because I got people who usually do this, but I will try my best.
I don't know. I'm probably a case study on its own because my primary said I needed all this for all the reasons you stated, even though I wasn't getting hot flashes, right? I couldn't sleep. No hot flash. I never really got hot flashes. And I started at 38.
Oh,
Okay.
wow.
So said I needed it to make sure I didn't, for bone health, heart health, all the things you listed, right? So he started me on estradiol oral with progesterone. Then I started bleeding. Then I had to go my uterine was thickening. Then like it was like a spiral of, I went to a new gyno and she said, stop everything. You don't need any of that. I'm like, oh my God, who is right? So I like need to bring them to a room so that they can battle it out, because like
Yeah.
I'm in the middle all confused as to what I need, what I don't need.
Yeah. Well, to me, it's like if you had diabetes, right? They'd send you to an endocrinologist. And I know the OBGYN's supposed to do that, but unless they have specific training in menopause, I would only go to somebody who does just this. In your case, because it's pretty complicated.
Yeah.
I had something similar happen when I was in my early 40s, and they tried me on it and my levels just skyrocketed, and it was, yeah, they're like, nope, time to stop.
Well, the bleeding is the problem. So like what do you do here if this is causing bleeding? Like what do you continue? Like what, or is that a sign something's wrong? Like,
Yeah, it's probably, and again, I'm not here to give anybody advice, uh, uh, but it's probably just the levels are off,
mm,
because it's a real delicate balance.
yeah.
Yeah.
So, I can tell you my experience. I've been on bioidentical hormone replacement for about 10 years.
Joe.
And now I'm actually on pellets. And mine actually didn't even start with estrogen. I had zero testosterone in my system, which no energy, it makes your life miserable. But throughout that phase, one of the parts of bringing in estrogen when I was starting to go into menopause is it does extend your period cycle, and you will have breakthrough bleeding. We just upped and downed progesterone versus estrogen levels as those things happened. But I put in the comments, my gynos, I searched for 5 years. I was so miserable, you guys. I went to every gyno. They tried to convince me to have a hysterectomy. They wanted to do an ablation. They wanted to do all these things. And I kept saying, no, tell me what's wrong in there. Tell me that there's something in there that has to come out, and then I'll believe you. My GP, clueless, absolutely clueless. A friend of mine finally introduced me to a bioidentical clinic. That's all they do is male and female hormones. That's their specialty. And you'll know exactly you got the right people, because like Vikki mentioned, there's a whole list of hormones they should be testing you for. And if they're not breaking everything down for you and talking you through all of those levels and all of those things, then it's not the right place. That's the fastest way I can tell you to look. Because otherwise, Western medicine mushes all of the hormones together. It's one test and it's skewed like you wouldn't believe. It doesn't help you at all. So that's my advice to you guys, is just look around, find someone. That's what they do. Don't, I would have had 4 hysterectomies by now if I believed all the gynos. And I just kept fighting. I'm like, nope, prove to me there's something wrong with her. And she's still here and she's fine. And I'm 10 years into it, and we are weaning me off,
I
because
just
now that I'm postmenopausal, I don't need as many hormones in that level. But we go by how I feel and my symptoms. Because like Vikki said, we're all different. What feels good for one level for me is not going to feel good with everyone else.
100%. I just put the link in, oh, yeah, I just put the link in the wrong place, sorry. I'm putting the link in the chat for that portal where you can look up providers in your area.
Fantastic.
Okay. Any other question? Somebody asked about weightlifting. It is absolutely encouraged. Not only is it good for bone density, but the #1 predictor of longevity is muscle mass. So lift heavy weights and eat lots of protein. Those are the 2 things that stimulate your muscles to grow: eating protein and lifting weights.
And the other thing that's really important is to strengthen your core. If your core is strong, you can prevent yourself from falling to begin
Yeah,
with.
balance.
Strengthen your core, strengthen your
fine.
ankles, strengthen your knees. That's what's going to prevent you from falling. Learn how to fall and not catch yourself. Learn
Which-
how to fall and not use your wrists and arms to catch yourself.
Do you
Another,
remember,
that's a
did anyone
good
go to
point.
Miraval last year? Did you do the slacklining?
No.
So sign up for that. It's this 10-foot strap balance beam that it was so good for my core when I was there. I did a private lesson because I had some extra credits, and I bought one for my backyard and literally have to walk across it to go to the trash can and back every day. And it has made such a tremendous difference.
That's awesome. I was just looking at that, Kimball. Now I'm going to sign up for it.
It's called a slack.
I don't know.
strap.
I'm gonna watch you guys because I heard Kimball go through this and I'm like, that sounds like torture.
Oh, it was totally torture, and it still is. I fight with the bar, but I know how to fall.
Yeah.
And I don't hurt myself when I do. And the core, like I can see a progressive difference. Plus, it helps that my mom and I go to the gym every morning. My mom's 82. She and I go to the gym every morning at 5:30.
Yep.
So
Awesome.
she has fans in the gym.
One last
Sure you do. Too.
piece of trivia that's related to this, and we didn't talk much about it. I was originally going to combine this with talking about the GLPs and weight loss, but there's just too much of each to do that. So there is really, believe it or not, no correlation between menopause and weight gain in general. There is a correlation between menopause and gaining fat. So that's, in all of the areas we don't want it. And the best way to lose fat is walking. So walking is what's called zone 2 training, and that's just a measure of how much work you're doing when you're breathing. So there's a really easy way to calculate it. You just go online and they have calculators, but it's 220 minus your age. I'll put that in here, 220 minus age times 0.6 to 0.7. And that's the range that you should keep your heart rate when you're walking. You should be able to still carry on a conversation, but that's how you burn fat. Not with HIIT. HIIT is actually, it's crazy. It's actually not great for us. Well, those of us that are, around this age, because it can put so much stress on your body that your cortisol levels are jacked up, and then you got more fat to deal with. Plus, I also hate HIIT, so just skip it.
Vikki, is there an extra character in your formula there? 220 minus age times 6.7?
No, it's times 0.6 to 0.7. It's a range.
Oh, got it. Okay.
I missed the bed mass. I missed the bracket. So
Got it.
0.6.
Okay.
Yeah.
Thank you.
You're welcome. And a lot of equipment at the gyms, if you hold the grippy things, they'll actually measure that, your heart rate too. And even some of them even show the zones you're in. Exactly, Molly. Yeah, you shouldn't go over that or your heart will explode. Not literally, no, it just feels that way. You're welcome, Kathy. Or is time up? Okay.
Oh, darn, it is. Shoot.
This was
That's
so
awesome.
timely. It was so perfect because I've been going nuts over this for the past 2 months. So I just want to say thank you, and Linda, for putting this together. It's like, what we need.